Good morning, everyone. I am Dr. Pauline Convocar, the President of the Asian Society for Emergency Medicine and also President-elect of International Federation for Emergency Medicine, and I will be chairing this session. This session will have two parts. Part one will be presentations or case studies from our colleagues from PNG, Moldova, and Ukraine. And this session is to exemplify the synergies, focusing on how EMT development interacts with and strengthens routine emergency care, and as we navigate as well, interrelationships between emergency care, critical care, and operative care and surge. Part two will be a consultation on the Global World Health Assembly resolution on the ECO strategy and action plan. And should time permit, we may also allow some questions directed to our speakers or panelists. So I encourage everyone to hold on to your questions until then. So for the first part, I'd like to ask our colleague, Dr. Kai Xiao, to present the introduction to the session and the interlinkages between strengthening EMT surge capacities and emergency critical and operative care systems. Let us please give Kai a warm round of applause.
Thanks so much for that, Pauline. So this presentation was actually meant to be given by Dr. Flavio Salio, but as he says, he's otherwise occupied at the moment, and I'm not quite sure if they've actually got my slide. It's a single slide. So my name is Kai Xiao. I'm a consultant with the EMT Initiative in Geneva, but I'm also a practicing emergency physician from Australia. And so this interlinkages between EMT, the emergency medical teams, and surge capacities with our routine emergency care systems is something of great interest, and certainly something that's very, very important. So I'll just ask if whether or not the slide is available or loaded. But effectively, it's a representation of the interlinkages, and I can describe it if the slide is not available. And it's a pyramid that demonstrates here we go, excellent. So basically, it's conceptualizing the interrelationships between our routine care systems and surge systems. Some of you probably are quite familiar with this pyramid or seen it before. And as you can see at the bottom, the foundations of a routine care systems and its relationship with surge response. Clearly, it's important to have a well-established and trained health workforce, as well as healthcare systems that is able to form the foundations of a response. But on top of that, it is necessary to build additional and specific capacities that is able to respond in a surge. So both of those elements are symbiotic. They're dependent on each other, but one alone is insufficient. So I think today we'll hear a few more presentations that give an example of that, where potentially you could have importance of foundational routine care systems that is important to build on when you have a surge or disaster response, but at the same time, sometimes this development of the surge response and capacities can also work to strengthen your routine care systems as well. So I'll leave it at that as a single slide, just as a framing introduction, and we can take questions afterwards.
Thank you, Kai. I just also would like to acknowledge our president of the International Federation for Emergency Medicine, Professor Fares Salas Alali. Good morning, sir. I forgot to acknowledge you earlier. And next up is a dear colleague who will be sharing experiences for basic emergency care in Ukraine. So up next is Dr. Katerina Barabash.
Thank you, Dr. Pauline, for the invitation. And generally, It's a great pleasure and a great honor to be here and to present the experience of Ukrainian team in implementation of basic emergency care. So my name is Dr. Katerina Barabash. I'm practicing orthopedic and trauma surgeon. And also I'm working with WHO Country Office Ukraine and on the position of Emergency Medical Services Officer. And can I have the, is it the, okay. So to start my presentation, it's really important to raise awareness about the situation in Ukraine, as despite the fact that this current full invasion lasts more than 2.5 years and already reclassified as protracted emergency, the impact of the situation is still high and does not become less intense, and still classified as level 3, the highest level of emergency. And with the recent attack, as you see, the September 2024 was named as the deadliest month in this year, as there was more than 200 killed and 1,200 injured civilians. And on the photo, you also see the recent devastating attack on the specialized hospital, high-level, tertiary-level children's hospital, Okhmandit, which is providing the care for children in different levels with really highly problematic issues with cancer, with kidney disease. And with this photo, I wanted to highlight that despite the timelines, the impact in the healthcare is still high, and healthcare system is suffering, and special emergency medical services from the disruptions in the system and the large volume of injured patients. And that's why implementation of basic emergency care was initiated as a part of response program for the urgent need of standardized care on emergency care on all levels. And introduction of the package itself has been identified as an important instrument of the response, but also the preparedness. So that's why a sustainable project has been developed. We know that generally basic emergency course is the foundation course giving basic skills and knowledge to all frontline workers. We have done additional assessment in the country about the applicability of the course specifically in country. And as current development of emergency care in Ukraine has made some significant steps forward, we understand that the target audience in country would be young EMS specialists, but also we have identified and has placed an emphasis for nursing specialists whose responsibilities are unfortunately less prioritized. And also, the role of primary healthcare also has been recognized in the target audience, as the immediate high-level care is especially important in remote areas and hard-to-reach areas. So, when we were planning the national rollout of BEC, first priority was to include that the program itself will be embedded in the national education system. And this will guarantee its sustainability after the initial response. So we have partnered with the biggest medical universities. We have a total of 14 of them, but we have selected several universities to start the initial process. And that's why this started the pyramid of the training, ensuring that the course will be integrated on both undergraduate and postgraduate levels. And project continues with the initial provision of the course by international faculty. And needless to say that Dr. Pauline Konvokar was one of those international BC mentors that helps us and inspired us in the provision of the course. So really appreciate your input and inspiration for us. And important to mention for the first courses that the target audience for the first courses with the representatives of medical universities with the previous experience of provision of standardized courses. It was important to us because this will allow to create a national faculty and then roll out of the training program on the front line already in Ukrainian, and this allows the program to be more receptive to the beneficiaries. And of course, in the same time, during the rollout, they have undergo the traineeship of new faculty during this provision of the training, and identification of participants with instructor potential was one of the tasks. Moving forward, that the accreditation and administration of international certified courses for the universities in Ukraine are still a new concept. So we have started the capacity building of the universities to teach their staff to how to administer and organize the course. So at this step, also after 3 traineeship, we have set up a full certified national master trainers in Ukraine. And as our further strategical steps is increasing the independence of educational institutions in rolling out of BEC and BEC TOT, but also inclusion of BEC program into undergraduate curricula and expanding course providers to the medical colleges. And also one of the priorities currently is establishment of national body for quality control and roster management. To summarize all mentioned in numbers, from the November 2023 until now, we have translated full training package into Ukrainian. We have provided 12 BEC courses, including newly presented conflict-related module twice, and 4 training of trainers. And this has led to 251 certified providers, out of which 94 has been identified as instructor potentials. And currently, national BEC faculty consists of 10 master trainers, 14 registered facilitators, and 36 provisional facilitators. Of course, when we are doing the project, we also paying attention not only the plans, but also the challenges which is existing or possible in the future. So some of them are the necessity of quality control in the growing infrastructure of course providers, but also the management of national roster and establishment of specific regulations, for example, the validity of the certificate. And this can be addressed by selection of institutional BEC champion who will be leading all these processes. But in the same time, the selection of institutional champion may have increased the risk of monopolization of the course program and also some of the conflict interest. Some additional challenges are adaptation of materials to Ukrainian protocols, national protocols, because there are some differences in it, or vice versa, recommendation to Ministry of Health about the adaptation of the national protocols to the training program. And also, one of the tasks and challenges as well is inclusion of the BEC into the general recommendation and requirements for set level and list of specialists working in EMS system. And in the topic of the event, we have also brainstormed about possible application of the BEC course for EMTs. And consider that BEC course is a foundation course. Its introduction to the standard or onboarding process may be a good application of it to ensure that all medical personnel working in the EMT is able to manage basic emergency situation quickly and efficiently. As part of quality control, as well, remaining certification of BEC may be included into requirement for set level and list of specialists. The same approaches are used for different courses in different organizations, such as remaining BLS certification or ALS certification. An additional option for use is maybe a capacity building of local staff during deployment. Of course, this is not the main task and priority for the EMT during their deployment, but provision of BEC may be part of exit strategy in case of stable environment during the deployment. And of course, it's important to mention that this option might be possible only in case there is certified master trainer a part in the team. So we have came to the end of my presentation. And of course, it's important to mention that I am representing a great Ukrainian team. with whom this project would not be possible. And this is the time when I want to share all appreciation to all people who are working to this project. And thank you for their inputs to make this possible. Thank you very much for your attention. And if there's any questions, do not hesitate to use my email on the slide, and there will be some time for questions. Thank you.
Yeah, thank you very much for the sharing, Dr. Bravash. And up next is our colleague from PNG, Dr. Gary Nu, who will be sharing about strengthening and synergies for emergency care and EMT. Right?
How do I go to next? How do you use the clicker?
I think it's play and this is backward.
Okay.
Good.
Hopefully my slide will come up. Thank you. Play, yeah? We can start my slide. Thank you, everyone. My name is Dr. Gary No, and I'm the national lead for the PNG EMT. For those who don't know, Papua New Guinea is a small island nation just above Australia with a population of about 12 million people. The country itself is made up of about 22 different provinces. These 22 different provinces impact on our response to various disasters. The country is prone to natural and man-made disasters throughout the year. We have a lot of volcanoes, we have landslides, droughts. Almost everything happens in Papua New Guinea. The 22 provinces all have different provincial health authorities, 22 of them, and all govern themselves, and the clinical capacities of each province is different across the board. This, as my previous presenter has also presented, there's skill gaps that vary, and for us it's quite evident, and this was noticed during the COVID responses. The basic skill sets to manage critical care cases and even just the basic application of oxygen care is lacking in many of our health workers across the country. With this entail and this gap notified, we needed some mechanism to provide training for the teams. And just-in-time training was one of our things that we embarked on to bridge this gap. So probably the best way to highlight this initiative is to go through the example of our OSCA training that we developed, which is optimizing standard care for oxygen. And this is a multi-specialized team that's deployed for this training, and it takes 2 days to train. We cover everything from oxygen concentrator installation, the care for the oxygen concentrator, right down to oxygen delivery devices, up to basic non-invasives care. So we cover biomedical technicians that are with the team, and IPC nurse, and also doctors that will provide this training for the local health centers and that. There were about 7 provinces that we deployed the training to, and about 177 healthcare workers were trained. This demonstrates the effective use of a national EMT in enhancing the clinical skills and capacity of patient care during the deployment and during peacetime deployments as well. So for our EMT, it's essentially a type 1 mobile EMT, a small team. We have informal specialized care teams that we can add on and deploy for trauma situations. My country is prone to tribal violence that erupts erratically at any time. And this poses significant risk, but it is something that we need to respond to as well. You've already seen in the previous slide that we have a specialized team for oxygen training and deployment as well, and you see that there. I guess the strategy is for EMT leaders as champions for emergency care, and also identifying emergency care champions in the provinces and incorporating them into the EMT team so that we can build that capacity together. Much of our capacity is based around the national capital and around major cities. But as you see from the map and what I've described, there's 22 other provinces that we need to cater for. Getting that skill mix out there to train the health workers is essential for us to make sure that we have a base knowledge and skill set in those frontline health workers, which will make our response easier for us. Our EMT also transitioned from COVID, which we were based in a national control center, and we were initially established as a primary response, clinical response to COVID. Right now, we've transitioned into the National Health Department and have been placed in national health standards under emergency medicine. I am also one of the deputy chiefs of emergency medicine in my country as well. This has helped us to be engaged in various conversations and being able to have a say in what is applicable for our emergency care, what can be used in our emergency care. Again, one of those examples of synergy between EMTs, but also having a say about what is important and what course is applicable for us. This is our small team, and as you can see, we have a few rehabilitation officers as well as pre-hospital care workers. So, in a snapshot for our emergency care systems, we have the OSCAR that I've described. We have IITT, the Interagency Integrated Triage Tool, that we have had a training on, a national leadership course, and a national rollout of trainers. Right now, for the triage system, we have 22 trainers. We have 44 trainers, 2 each for every province across the country. So we're currently rolling out the national triage system. For basic emergency care, we are thankful to ICRC for their help and the development of 3 master trainers in the country. Difficulty with BEC right now is the master trainers are based in the highlands of Papua New Guinea, nothing in the capital of Port Moresby. Logistics is difficult for us because every flight has to come out of the capital. Where is our EMT based? It's based in the capital. So we are currently in the mode of building capacity in the PNG EMT for our master trainers to be based in Port Moresby and then deployed and building the, having the training, BC training in other countries. We are thankful to also our partners with NCCTRC for providing MIMS and HMIMS training for our country, and myself and 2 others are also faculty members and instructors for this training, and we travel across the Pacific. Pacific instructors teaching Pacific colleagues. Primary trauma care is also one of the courses that we have, and it's been in our country for a number of years now, so it's well established. Our national ambulance system, we don't have formal national ambulance system within our government system, but we have the National St. John's Ambulance in PNG, which provide our pre-hospital care and training for us in country. I guess to finish off, I'd like to say that for us, we lean into partnerships a lot. From the PNG EMT and the health department in which I am based, I was the former president of our Emergency Medicine Society, the Papua New Guinea Society for Emergency Medicine. Through there, we were able to partner with the Australasian College of Emergency Medicine, and you'll see the BC and IITT and a lot of our friends, Rob Mitchell, Georgina Phillips, and all of these colleagues that come across, and they help us to strategize and build these systems within our country. We're building our major incident response with partnerships with the National Critical Care and Trauma Response Center from Australia, and we are appreciative of these efforts as well. The EMT leans into WHO a lot for technical assistance for its development as well. I'd like to finish off by saying that Pacific Island Society for Emergency Medicine is currently established, and we will be launching it next year. And this might be a medium for us to have emergency care initiatives driven through the Pacific. Thank you very much from Papua New Guinea. Thank you.
Thank you, Dr. Gary, for your presentation. It's very important to emphasize that the strengthening of standardized care is very important, while, of course, also responding. Up next is our colleague from Moldova, who will be also sharing strengthening surge capacities to strengthening health systems. Please help me welcome Dr. Vitaly Stetsik.
All right. I have no conflicts of interest to declare. And while preparing this presentation, I was trying actually to answer one fundamental question. How does building surge capacities improve the health system? Because we tend to see that there is a lot of thinking in silos, but I'm happy to see that this session here is actually breaking those silos and making sure that we are all moving together, because we can contribute jointly to building surge capacities while developing health systems. To start from, I would like to introduce to the context, operational context, which we have in the country. So Moldova is a middle-income country. It is low-middle-income country according to the World Bank classification, so which means that there are not many resources, both financial and human resources in place. So the specialty of emergency medicine is under development. So just recently, Moldova introduced the system of emergency departments, shifting from the pre-existing systems of admission departments and where the care is not really structured and provided according to the ABCD approach. And unfortunately, the country is seeing ongoing emergencies, starting from the COVID, then the outbreak of the emergency diseases like monkeypox, but also the unfortunate situation in Ukraine. The war in Ukraine triggered a biggest refugee crisis the country has seen so far. And Moldova has been one of the countries of the European region which has been affected most by the refugee crisis. Over 1 million of people crossed to Moldova from Ukraine. And just to give you an example, the overall population of the country is around 2.5 million. So you can see really a significant impact. And Moldova, therefore, has been exposed to the large-scale international response, which was not really something the country has seen, which means that there is a lot of need to coordinate various partners, various stakeholders, and make sure that this response is actually benefiting both refugees, but also the vulnerable host community, because we are working in the dual track approach here. So if you look at the GE, Joint External Evaluation, just to see what are the Just to see what are the pre-existing capacities, we can see that point R.4, medical countermeasures, indicates that we have limited capacity, which actually proves and gives the evidence to what I just mentioned about limited resources. So our initial task was actually a straightforward one. We started working on building surge capacities for trauma and mass casualty management in the country. Making sure the country is ready for the possible emergency. The Ministry of Health was really interested and was really driven to prepare for the disaster in 2022. And basically, we started our work from building surge capacities for trauma with the focus on mass casualty management. And here, we've been using various WHO tools like MCM toolkit, to work on the different level, working at the national and community level, working on the hospital level, developing practical guidance, developing hospital contingency plan and putting them in place, educating healthcare workers, training them, and making sure that the hospitals are equipped. So you can see 5 points here, and we've been strongly collaborating with EMT because EMTs were helping us to actually reach education, make sure that, that they transfer their experience and knowledge on how to handle mass casualties to the country which was not exposed to this pretty much in the past. And EMTs were used also for the capacity building purposes. And this is the slide actually which I got from my colleague from HQ, which actually shows very well. And this is something we really understood while working on the topic, that in order to make sure that your surge mass casualty management capacity is in place, you need to ensure that previous steps, it builds upon the foundation of pre-hospital, facility-based emergency care and operative care. So basically, we came to this realization while responding, and more we started building on the mass casualty pathway. We understood that we cannot ensure quality health services in the emergency unless we continue investing in the foundation, meaning establishing emergency care system in Moldova. And throughout response, you can see at this slide the different phases of the response. We were lucky to have Lee and his team conducting emergency care system assessment, which we were using as the frame, as the foundation to understand what are the gaps and what are the priorities where we need to invest in building emergency medicine in Moldova. So in 2022, we started from mass casualty work and collaborating with EMT. And in 2022, we started adding up the foundation of emergency medicine through putting basic emergency care course, through putting the trauma-related courses, and making sure that the people working in emergency departments are having this baseline training through basic emergency care. Because Moldova, like many countries in our region, in Europe, unfortunately, emergency medicine is still a new specialty in the region. Even in highly developed countries, sometimes we don't have emergency medicine specialists recognized by the Ministry of Health. So basically, we are in the environment when the country, the emergency departments, they employ GPs and various level of specialists. And with BC, we started forming a foundation, making sure that all the patients attended for the emergency conditions, they are treated in the structured and quality way. And later on, we started building hospital mentorship program, making sure that all the trainings and guidelines we help country to develop, it is being instrumentalized through deployment of our mentors and trainers who work in the hospitals and help to put this all in practice through on-the-job support, simulation, etc. So here at this slide, you can see how we the point of arrival, this is the program which we are implementing right now. Driven from the mass casualty work, we now implement the holistic emergency care strengthening program. If you follow the QR code, you can get more details on the program. For the sake of time, I'll not stop here. Just to mention that we are working based on the implementation science approaches, and we are working to make sure that we develop guidelines, we develop hospital standards, SOPs for emergency medicine. Then we train people, we train healthcare workers, then we have mentors working in the hospitals, making sure that clinicians actually employ those skills in the real life situation. And then we do the feedback loop and we learn and we do clinical audit just to make sure that the clinicians are utilizing those skills. And now we are about to start quantitative research to see actual impact on morbidity and mortality in the emergency departments. And here at this slide, I just highlighted the synergies where we collaborated in the past with EMT and where there is a room for potential collaboration. So EMT were used to support us in the mentorship and to support us in the training pathway, but pretty much sure we need to work together to make sure that EMTs are better integrated and EMT work is highlighted in the clinical pathway just to make sure that the transfer protocols in place, etc. So at my last slide, I wanted just to put a bit of a lessons learned and just to answer that question. So first of all, while working on the surge capacities, we need to make sure that we build foundation of emergency care in the countries where emergency medicine is not developed and is not practiced regularly, to make sure that EMTs deliver quality and safe services during emergencies. When we designed our emergency response, we initially thought about the development angle, and we made sure that the emergency response includes possible opportunities for emergency care development, and we've broken down silos, and we try to work together with emergency medical teams and our ECO colleagues just to make sure that we holistically approach the problem in the country, and we holistically make sure that more people are protected from emergency, and in case emergency strikes, we can reduce morbidity and mortality. Thank you for this, and we are presenting this program at the booth 15, so can we return QR code, please, for a moment? And if you scan the QR code, you can get more details about the program. Thank you very much.
Thank you very much, Dr. Vitali. And apologies, but we will not be able to accommodate questions as of this time. But definitely you will have opportunities to approach our dear presenters for these. We have heard 3 presentations highlighting the synergies between emergency care systems and surge capacities for health emergency preparedness, and now we're ready. These are perfect segue to part 2. So I'll be handing over the floor to Professor Lee Wallis. Everyone? Professor Lee Wallis. Would you like me, or would you like me as an assistant?
Good morning, everyone. Thank you for the opportunity to have this session here. It's a very important part of our global consultation. So I'm Lee Wallis. I'm the lead for emergency and critical care at WHO headquarters. If you could just put the slides up for us, please. So I have a few slides to go through, and then the important part of this session is I need you to be on your phones, please. We'll show a QR code at the end of the slides for a Slido poll. This session is to get your input. It's your opportunity to give us guidance on what should be in a really important global strategy and action plan that I'm going to tell you a little bit about when the slides come up. So just, yes, sir? Just give us 1 second for the IT. Okay, some small challenge with localizing the slides. So let me just tell you a little bit about what the session's about. So WHO is a United Nations health body. So like the United Nations, as the high level, it's run by 194 member states. So we work for the member states. The United Nations gets its mandate, its work instructions from the member states each year at the General Assembly, and we get our instructions from the member states at the World Health Assembly. It's held in Geneva every May. At the World Health Assembly, the countries come together and they pass resolutions and decisions. And those resolutions tell us our work plan. Resolutions are always structured in 3 parts. There's a background framing what the problem is that's trying to be addressed, what the issue is, the topic. There's a part that requests the Director General, so instructs WHO basically to do some actions to provide technical support for countries or to help develop content and so on. And then suggest some ways in which countries can strengthen this particular part of their health system or their health services or their emergency preparedness or response and so on. So we frame the problem. The resolution then says WHO should act on these things over the next few years, and countries can do these things. These are best practices that countries can do to improve their health provision in this area. So over the years, since about coming on 20 years ago now, there's been a number of resolutions related to emergency care, to surgery, anesthesia, and to provision of care during surge. Some of you will know, for instance, 6815 from the 68th World Health Assembly, which is about essential and emergency surgical care and anesthesia. 7216 was just before COVID. It was about strengthening emergency care systems. But the one I'm talking to you about, why I'm here today, was passed last year in 2023, and it's Resolution 76.2, and it's called Integrated Emergency, Critical and Operative Care for Universal Health Coverage and Protection from Health Emergencies. It's a long title. It basically means three things. One is that in your health system, you should not have silos for patients who have acute care needs. Care, as you've seen on the slides this morning, care should be seamless from a patient perspective, from the community through pre-hospital care and through facility-based care into rehabilitation and back into the community. And if you get that system right, as you've just heard, for instance, from Vitali, from Kai's pyramid slide, if you get the base of the system right on a day-to-day basis, universal health coverage, then that is the system that responds during surge. So when the system is stressed, when there's mass casualty or when there's conflict or when there's a pandemic, that part of the system is what continues to function to be the point of access for patients. That resolution laid out a number of key steps that countries can take and key instructions to WHO. And I want to show you some of those because that's what we're going to ask you about on the Slido poll. But one thing that was missing from the resolution was a mandate to develop what's called a global strategy and action plan. So some of the most powerful documents that you can have coming from WHO and from the, from the World Health Assembly to instruct WHO on course of work is a global strategy and its associated action plan. So we're talking about two separate documents here. And in this year's World Health Assembly, we were given a mandate, a decision 77.8. These are the old resolutions, sorry. So this is the resolution that I just mentioned, 76.2. You can get it from the QR code. And then this is the mandate that we were given. We've been asked to develop with member states a 10-year global strategy and associated action plan that will inform how emergency, critical and operative care should be provided in countries or could be provided for the best cost-effective use of your resources and potentially the best clinical outcome for your patients. So this resolution, just as I said already, the first part is framing the issue, but what you need to know is on the side here, which is that ECO it's a integral part of a primary healthcare centered approach. So it's a system which takes care as close to the patient's place of residence as possible and is focused around patients' needs and family needs. ECO is essential as the foundation to be able to respond in a large-scale emergency. So the things that suggested for member states to do in this resolution, you've heard some of these already, like all of the work that's been happening in Moldova that Vitali just spoke about, came from the national assessment, the ECSA, the national assessment of the system, and the recommended actions that came from it. The resolution goes on to advise that ECO should be integrated into national health strategic plans, that there should be governance mechanisms in place, there should be mechanisms to make sure that during disasters, large-scale emergencies, that access to ECO services is maintained as an essential health service, that we should educate the community both on when and how to access care, but also how to provide care as first aid trained responders. There should be timely and reliable pre-hospital care for all, and that there should be a number of key processes like the IITT, the triage tool that you saw is in use in Papua New Guinea. And there should be appropriate regulation and certification mechanisms. Training, lots about training in there, and then a call to countries to have standardized mechanisms for standardized and disaggregated data collection. In terms of the request to WHO, so this is really an instruction for the team that I work with, clinical services and systems. This is an instruction for us for the next 10 years. We need to help countries to strengthen their routine services and their ability to respond in times of crisis. Make sure that we have collaborations in place. Produce technical guidance. For instance, we're very close to launching a pre-hospital toolkit, so a wide range of tools for ambulance services, from operational guidance, how to run your fleet, how to maintain your fleet, through to clinical guidance and everything in between. And we should support member states with, it's not just about the service delivery, but also the mechanisms such as financing, sustainable financing, and so on. And we have our first report back on progress against this resolution in May this year, or May, the upcoming assembly in May 2025. So based on this resolution, there's three things that we really need to do. One is network. So we just held the first meeting of our global acute care network. It's called the Acute Care Action Network. It's currently got about 50 professional societies and foundations in it, and we're aiming to increase that to somewhere around 70 or 80. And the point of the Acute Care Action Network is coordinated implementation to make sure that we can support your efforts to introduce WHO tools in country in an effective and sustainable way. But the other part is strategies and action plans, and that's why we're here today. A global strategy is a really key document that lays out it's only 5,000 words, so it's a reasonably high level, but what are the key things that countries can do and what WHO can do to strengthen, in this case, emergency, critical, and operative care. So we're going to take you through a Slido poll. I would really like you to have your phones. This is not about me talking at you. This is about you giving us inputs. This consultation is our 15th global consultation on the development of this global strategy and action plan. We have about 5 more planned by the end of the year. At that point, we will develop, based on all of the expert inputs we've had from professional societies and from clinical groups. So this is consultation with ambulance services, with disaster responders, with doctors, nurses, across the whole range of ECO services. We take those inputs and we draft a global strategy and a proposed global action plan. We then go into the second phase, which is regional consultation. So we go to our 6 regional offices. We've started that engagement with them now. Then in the first quarter of the year, those regional offices undertake their own consultation. They may do it with professional societies. They may only do it with governments. That's entirely up to them how they do it. And they feed that back into us, and we make a final draft of the global strategy and the global action plan. And then we take that into consultation with the countries. Our requirement is that we bring those documents to the World Health Assembly, not this coming May, but in May 2026. So we have still about a year to develop those 2 documents. This is the first part. We're coming towards the tail end of this first part of the consultation, which is to get professionals, doctors, nurses, paramedics, wide range, rehabilitation specialists, a wide range of clinical and first contact providers and hospital-based and ambulance service-based primary care providers to answer 7 questions. The 7th question is anything else that we're missing, but there's questions about service delivery, capacity building, access to products, quality improvement and data, financing and advocacy. We're going to pop up 1 question at a time, and we just want you to go on the Slido poll and just give your opinion. It's completely anonymous. So you can say as little or as much as you want, but I promise you that every answer that we receive, we are analyzing. We're looking for, is it a theme that's come up before? Is this a new theme? Is it a new topic? We're listing them all out. We consider every single input that we receive. We will be producing a draft of both of these documents based on this input, and on literature reviews, and on gathering some primary data. For instance, we're busy with some research to try and look at hospital eco services in about 2,000 hospitals across 100 countries at the moment. Because this will be published, it will be used to develop a global strategy and action plan and some associated documents. We do need your consent. The fact that you're staying here and doing this Slido is consent to participate. We're not asking you to sign anything, but you need to know that the purpose is that we get expert opinion to help inform the development of these documents. The data is completely anonymous. You'll see some answers come up on the screen. You won't see anything that associates with your name or your phone or the fact even that you're in this room. There's nothing identifying that's stored, and we store the data on a secure server that's only available to our team. You're just asked to go through a series of questions. I think we'll do it in half an hour. We should be okay for that. There's no direct benefit to you, but you are informing this really important. This document will be in place for 10 years. For those of you, which I think is everyone in the room, who work in emergency, critical, or operative care, this will be driving governments and ministries' behavior, actions, strategies, thoughts in eco-service delivery for the next 10 years. And it'll be driving our work at WHO. So it's really important that we get robust inputs. And of course, the benefit to the world is potentially huge. You can start filling in the answers and then you can stop. You can go through all the way through. And please, there's a csy@who.int email. If you have any questions or comments about it, you can just come through to that. What I'm going to do now is just leave this QR code up for a second. I would ask you please to just scan the QR code, or you can go on, if you're using a laptop, you can go onto slido.com and you can enter ECO #4 UHC and it will take you to the survey. And what we're going to do for the IT guys, please, is swap from this screen to the Teams meeting, where my colleague Andrea in Geneva is sharing his screen and is going to the questions will come up. I'll take you through the questions. What we want to know for each question is, when you type an answer, please don't type an essay. It's just a short answer, a few words. But let's say the question is about capacity building. You might say, we need training. Okay, but that's very generic. Like, I don't know what to do with that. So you could say, for instance, universities, so an actor, who's the actor responsible? Universities should ensure acute care training in undergraduate programs. So an actor and an action. That's what we're looking for, each of these statements. Who should do it and what is it they should do? Tech support, can we swap to the Teams, please? Okay, this is the Slido, and Andrea, hopefully you can drive this from your side. Andrea's listening in. I see him on the screen there, sitting in Geneva. So the first question will come up now. Please use the link, and then just, you can answer as many times as you want. You just put in your answer, a sentence or so, hit return, and then you get the chance to answer again. When we move on to the next question, you can't answer the previous question, though. Andrea, are you good? We still got the QR code on the screen. Okay. What are the key actions related to service delivery processes? So this is frontline care delivery with a patient, an engagement between a clinician and a patient. So you might say, for instance, government should ensure that all hospitals use a standardized triage tool. That's an example of a service delivery process. Please just type away. You can see at the top, 6 people are typing at the moment. Just type your answers, hit return, they're going to appear up on the screen. We have no idea who it is that's answering. And then we will, when it drops down to just a handful of people, we'll move on to the next question. Okay, so a few people suggesting guidelines, protocols, SOPs across pre-hospital care and facility-based care. Coordination across the systems coming up a few times. You can see the keywords at the top. A lot of people suggesting triage. Governance is coming up a few times as well. Recognition of the specialty. There are other questions where these sort of governance mechanisms come up again as well. Care provided based on local resources, so that's an important one, that is sort of contextualization, guidelines, checklists, and protocols. Couple of people still going. Those put in training, the next question is about training, so you have a chance to flesh that out more in the next one. A lot about standardization, and that is a topic that we see coming up a lot in other consultations also. Okay, there's still 9 of you going. Okay, so you can see, those of you who are able to watch the screen, I know I've asked you to be on your phone, so you're looking at your phones. There's some very specific things at the sharp edge of patient-clinician interaction, and there's some at the sort of policy level and everything in between. Let's move on, Andrea, to the second question then. We're down to the last 1 or 2 people. This is specific to capacity building. So this is about improving the ability of clinicians, managers, administrators, people in the pathway somehow of emergency, critical, and operative care. How can they do their job better? So this is about them as individuals and not the system that they work in or the services they have available. Just a reminder, please, to try, where possible, just put who would be doing, so a mentorship program, who's the actor, who's responsible for that? Collaboration with international institutions is great recommendation. Who is it? Is this a ministry collaboration? Is it universities? Is it across multiple different institutions? Okay, so there's a lot coming across about training, obviously, it's capacity building, but mentorship is important. Needs-based and some research or data to support what's happening in country, it's a common theme. Collaboration, that's very good. Thank you, whoever said don't ignore nurses. It's usually in our engagements, it is an overwhelming preponderance of doctors. That is a reflection of how professional organizations have grown over time. We're very, very aware, and we do try very hard to make sure nursing voices are represented. Please keep telling us if we're not doing that. If you see some opportunities on these inputs to specifically call out nursing, please do that. Collaboration, that's really good. So low fidelity, I guess there's quite a few things coming through about locally appropriate. So if you're doing training, it being locally appropriate, team-based training, pathways from, so it's not just facility-based. Remote training, I'm assuming, meaning like hybrid, so you don't need to be out of your work environment. But yeah, interdisciplinary teams, team-based, very good. Still a couple of people going. Yes, thank you for calling out rehabilitation. That's really important. And open access. The cost of courses is a major barrier we see again and again. Okay, let's let these last few comments come through. Yeah, there is obviously, just from how trainings happen and the link with experts, specialists usually, there is a move to big cities usually, so actually getting people out into the rural areas is really important. AI may help with that, of course. System angle, standards, and training concepts. Very good, very good. All right, Andrea, I think we're down to the last one or two, so let's switch to the next question, please. So question 3 of 7, access to products. So this is, making sure that you're able to get the drugs that you need, the IV fluids, monitors, and things like that. So this might be about supply chain. It might be about making sure equipment is appropriate for your context, maintenance of equipment. Those sort of issues come in here usually. So supply chains coming up a few times, sort of standards, particularly a couple of calls to WHO to have these standards about what should have, stockpiling or predetermined supply stockpiles. And there were a few comments further down. Love the capitals and exclamations, a lot of enthusiasm. But that's another comment about being locally appropriate, locally procured in many cases. So the common problem that we see, donated equipment with no maintenance plan, and it's not appropriate for the context, so resolving those sort of issues. So locally appropriate equipment, making sure children's equipment is in there. Lists of essential requirements, we are working on that. We're about to produce those for ambulances, for example. We have them for emergency units. We're working on them for critical care and surgery and anaesthesia. Biomedical technicians, yeah, absolutely. That's a message that comes through strongly as well, that it's not just having the equipment, it's maintaining it. Otherwise, it's no use. National Rifle Association. Okay, someone might need to help me out. The only NRA I know is the National Rifle Association, and I'm assuming you don't mean that. Thank you, thank you. National Regulatory Agency. Either or. We don't know which one you meant. Okay, very good. Very good, thank you. This is great. And I know usually we allow a bit more time for this, but you're really working quickly within the time constraints. Thank you. Data quality improvement and research. So who's responsible? What should they do around using data for research, doing research, using data for surveillance, using data for quality improvement? Okay, integrating research and QI into routine practice. the role of the ministry in making sure that it's a sort of daily thing. AI comes up a lot on this for data analysis and aggregation. The role of nurses, that's really important again. Having a shared vision from the ministry, very good. In my package, excellent. Research into implementation, we know that there's this sort of 17-year cycle to get from something being shown to work to it being widely used, so trying to get that sorted out. Getting ECO properly on the research agenda. Funding is coming up a few times. Partnerships with academic institutions around training, but also around doing research and using data. Yeah, bringing patients in, patients and the community, very good. Very nice. Rehabilitation, thank you. Whoever keeps calling out rehab, really appreciate that. It's easy to just say ECO very broadly, but it's important we call out, I think, both nursing and rehabilitation as explicit things to make sure that we're not missing. Cross-system collaboration, very good. Okay. Andrea, I think just give it a second more. There's 5 people. We don't want to miss those last couple of ones. Okay, I think you can probably switch across. Question 5 then. It's only a couple more. Thank you very much. Financing. It's totally fine if we get less answers here because I don't know the people in the room, but I suspect if you're like a normal group of clinically oriented people, financing is a whole different world to you. So we usually get answers from the doctors, nurses, and so on that financing should be responsive to local need. It should be driven by data. It should be sustainable, things like that. And that's totally fine. We don't need detailed things that you might expect a Ministry of Finance to come up with. Just your thoughts on financing. So insurance schemes often come up here, for example. National health insurance for emergency care, novel funding schemes is important. Yeah, creative ways that are country developed. AI is a common theme through a lot of these, so the potential role of AI. Indicators so that you can actually show responsiveness and value. Public-private partnerships, very good. Bless you. It is totally fine if you need to write in Spanish or French, something that we can deal with the major UN languages. Andrea can deal with Italian if you want to write in Italian. Yeah, showing cost effectiveness and cost benefit, very good. Community-based financing strategies is nice, I like that. Use of data coming up a lot. Rehab, thank you. Now you're just doing it to make me happy. Okay, let's move on to, okay. Oh, you know, I'm a UN employee, so I'm not reading that one. Let's move on. Thank you, Andrea. Advocacy. What needs to happen to advocacy? We have a catch-all. The next one, question 7, is just anything else that you haven't said up to now. So advocacy is the last specific question. Advocacy is integral in action. Yeah, very good. Including the communities, and by that, I'm assuming we mean patients as well. Local voices, rehabilitation, exactly. So motivating for your own areas. A lot about patient and community, both getting their voice in, but also making sure that we advocate effectively to them. Exchange programs, that's new, that's very good. Some comments on the types of people and groups that we should target. Multidisciplinarity has come up a few times across different questions. The youth, engaging youth, that's great. There are some good youth organizations in certain areas that touch on us, like road safety, for example. Advocating not just for access to care, but advocating for retention and recruitment strategies. So thinking of advocacy in several different directions. Learning from history, good. Okay, last couple of comments. And then, Andrea, let's do thanks, everyone. These are really great comments, all of them. So this is just anything else that you... So we've asked you about service delivery, capacity building, access to products, financing, advocacy, data and quality. There are 6 broad areas. Is there anything else that you'd like to say? This is your chance to give the WHO Secretariat your comments on what would be in a global strategy and action plan to ensure integrated emergency, critical and operative care, both for day-to-day care and for the ability to respond in crisis. So please just drop any comments up there. I'll remind you again that email csy@who.int. You can send us any comments. We do have some other consultations coming up, including on the 12th of December, a sort of catch-all consultation where we've got, it's an open Zoom with ability to have 10,000 people on it. So anyone who you feel would be good to give an input, please direct them to us and we'll give them the link for that. We are working very closely with the rehabilitation team at headquarters, just to pick up that point again. And we work very closely with the Office of the Chief Nurse, who, by the way, is one of the biggest fans of basic emergency care. She's from small island state in the Pacific and really sees the value of basic emergency care and is pushing it out very aggressively into nursing. And I'm not going to try and summarize these because they're across a wide range. And you'd see if there were common themes coming, they'd appear at the top of the screen anyway, but really appreciate this. Pauline, I think we'll leave it to at that point. And ladies and gents, I can't tell you this is so important to the work that you all do going forward. And to making a difference in patient outcomes and the equitable use of resources and so on. So thank you from us for your time and effort in contributing this morning. Thanks.
Thank you. So thank you very much, Professor Wallis, for that. For anybody of you who'd also like to know more about the Federation, the International Federation for Emergency Medicine, we also recognize our role as part of rolling out and supporting this initiative. Our booth is just across this plenary hall. We are all together in this, and I'd invite everyone now to our lunch break. For those of you who still have questions, you may approach all of our panelists here in front or probably perhaps side meetings on the hallways. Thank you very much once again. It's been an honor sharing this session.
The development of the Rescue EMT was launched in December 2022 and brings together 8 partner nations hosting 20 medical capacities to be deployment ready and classified by latest September 2026. The aim of Rescue EMT is to strengthen the emergency medical assistance for affected population in sudden onset disasters and health crises. The Rescue EMT capacities can be deployed standalone, coupled, or self-sustained to support the national response efforts on health in disaster areas. Belgium provides the Burned Rapid Response Team and the Mother and Child Specialised Care Team. France supports Rescue EMT with an Emergency Medical Team Type 2 and the Specialised Care Team for the rehabilitation service of complex trauma patients. Germany coordinates the overall project and provides 3 capacities. These are a truck-based ICU specialised care team, a medical laboratory specialised capacity, and the psychosocial support specialised care team. Italy provides the portable CT scan specialised care team, a specialised capacity for oxygen supply, the dialysis for patients with chronic needs specialised care team, and a truck-based ICU specialised care team. Luxembourg provides vital connectivity across all capacities with the telecommunication specialised capacity. Portugal contributes the patient transfer specialised capacity and one of the oxygen supply specialised capacities. Romania is supporting Rescue EMT with 1 emergency medical team Type 2 and the pallet-based ICU specialised care team. Finally, Turkey contributes another emergency medical team Type 2, 1 oxygen supply specialised capacity, the complex orthopaedic treatment specialised care team, and a medical laboratory specialised capacity. Aligned with WHO standards, the Rescue EMT project highlights the importance of collaboration across Europe and beyond. By working together and sharing resources, expertise, and knowledge, we strengthen our collective preparedness and ensure a more effective response to sudden onset disasters and health crises. Rescue EMT demonstrates the spirit of solidarity across Europe. The initiative is funded by the European Union, while the capacities are provided by 8 member states and participating states of the European Union Civil Protection Mechanism, with the support of national and international partners.
So, distinguished guests, dear colleagues, dear friends, I have the pleasure and honor to welcome you to the lunch break session on Rescue EMT, and I try to keep short, to keep more space for the discussion and the interactivity, I hope, within that session. It's not going to be a DB PPT, dead by PowerPoint presentation. There are going to be a lot of questions and hopefully also questions from the audience. But also let me express our gratitudes to, starting with the Commission, to give us, Johanniter, the trust, and as I am the director of the EU Competence Center for Civil Protection and Disaster Assistance of Johanniter, I do that specially to coordinate the project and give us, as I said, the trust to accomplish this, as we usually call it, ambitious project. Second, also my gratitude and big thanks goes, and please forward the message to WHO for their excellent support in the project. Because one of our prerequisites already in the proposal phase was that all the capacities in the project should be classified under the, let's say, guidance of WHO, not to create something which is out of space, which fits into the landscape of EMTs globally. So again, thank you for having you here, and I hand over for the moderation to Bastian Harms, please.
Yeah, good afternoon, colleagues, as well from my side. My name is Bastian Harms. I have the pleasure to be the coordinator of Rescue EMT, coordinates the project amongst the 8 consortium partners from the member and participating states of the Union Civil Protection Mechanism, and on the other side, the European Commission, who is providing funding but also advice. Let me just give the chance to our panelists today to introduce themselves. You have just heard the welcome words of Mario Di Gennaro, Director of the EU Competence Center of UNITA Germany, representing the German Rescue EMT consortium partner, but we have 2 other consortium partners and 2 colleagues from the European Commission here on the stage. So let's start with Marcel, please.
Good afternoon, I'm Marcel from Belgium, and we're a partner in the Mother and Child and the Burns specialized cells.
Thank you, Marcel. Joanna, please.
Good afternoon. My name is Joanna Drogowska. I work in the European Commission in DG ECO. And since I started working there in 2019, we have started discussing the EMT project. And since then, all the last 5 more years, I've been working on the development of the project. Matteo?
Yes, good afternoon, and thanks a lot, colleagues, for this interesting session. I'm Dr. Matteo Noci. I'm from the European Commission, same team as Joanna, and we are working on the medical files, not only on the rescue EMT, but we also cover other medical capabilities implementation. Thanks.
Good afternoon. My name is Yves Cardoso. I'm from Portugal, from the National Institute of Medical Emergency, and we, as a partners, have here the transport cell and the supply oxygen to this project.
Yeah, thank you so much to our panelists to introduce themselves, and the kind request to all of you to speak a little bit closer to the microphone so that it's easier. Ivo, I could understand you perfectly, but partly it was a little bit too less from the loudness. Let me ask the first question. This is dedicated to our colleagues in the European Commission. What is the background of Rescue EMT project?
Could you repeat the question? Sorry, what is the?
Yeah, what is the background? What was the matter to establish a number of medical capacities under rescue, which means under the European Union Civil Protection?
Perfect, thank you. Maybe to start, the rescue was created to be a safety net. So to have something at the European region, some capacities to respond that could be used in the moments when countries are really overwhelmed, when we have cross-border emergencies, when not only single countries are overwhelmed, but also solidarity from other countries and the support from other countries is difficult because few countries are overwhelmed at the same time, like we often see in the fire seasons in Europe in the summer or during the COVID pandemic. So we did see that at a regional level in the medical fields, there was scope where we can do more, and that was the beginning of the discussion on developing emergency medical teams. Those discussions were led with member states, with participating states, and at the very beginning, maybe not at the very beginning, but at some point there was an idea to have an EMT3 in Europe, because we don't have one. However, with the time, we realized that it would be good to have something that is more modular, where we also have more specialized teams. And that was exactly at the same time when WHO started developing specialized care teams and was also highlighted the importance of having capacities that are flexible and modular. So that was the beginning of the thinking, and then of course there were a lot of discussions with all the countries, with WHO, how to create it and how to go forward. But I will also give the floor to Matteo.
Thanks, John. I think that you explained very clear indeed with the Rescue EMT, we are introducing something which is completely new, at least for Europe. And the idea was to offer some tailored assistance during a disaster and crisis. And this is on top of what we have already, as you probably know, as European Commission and member states in particular, they can offer other medical capabilities. We have already some 10 EMT-2 and several EMT-1. But that was not enough, and we realized that in particular during complex emergencies we need to have some more particular or very specific assistance. And that's the reason why the Rescue EMT is composed by 3 EMT-2 and a very significant number of specialized care teams. We are implementing 18 specialized care teams. In this way, our opinion is that we can be very effective in responding to emergencies. Of course, the Rescue EMT, as my colleague Joanna was explaining, can be activated only if all the other level of responses are already activated. So this can be considered this can be considered as a very only and only last resource approach to emergency from the European Commission.
Thank you so much to Joanna, and thank you so much to Matteo. As the organizers of the WHO EMT Global Forum 2024 ask us to have an interactive session, you can always ask questions to our panelists at the end of our session. Unfortunately, it was foreseen that you can choose between the number 1 to 6, but this is based on the technique today not possible, so we have to follow the numbers 1 to 6, and these are the questions. I have to excuse for this inconvenience, but we cannot change the technical system. We will ask some questions to the panelists, and this is behind 1 to 6. And I will ask our consortium partners, what is from your point of view, Rescue and the 20 new medical capacities being built under Rescue EMT? And probably if you see our flyer, there are 21 in, and I assume that we will have also in the near future, again, 21, but currently we can only speak about 20, which are just in the phase of the establishment. So, can I ask Marcel, what is your expectation, what is your view, and then afterwards the same questions to Ivo as Portuguese consortium partner?
Well, for me, Rescue is a European project. Collaboration, cross-border, together, and we're expecting to bring in the best of our people into all of these modules. So even in the Belgian developing model in burns or in mother and child, we don't just look at Belgian specialists. We also look cross-border to have these modules ready 24/7 to be deployed, and to be deployed within Europe or outside of Europe with the people we need on a need-based assessment, and deploy them whenever we need them. So it's more than just being a module, a specialized cell. No, it's crossing borders, it's putting people together within one unit being the rescue environment.
Thank you so much, Marcel. Ivo, from your point of view, what is the Portuguese motivation to be part of this Rescue EMT project?
Thank you for the question, Arms. In our opinion, we see this project as a capacity to take or to find solutions for some lakes during the deployments that we face. For example, in some missions, the lake in the referral capacity or in the transport of patients, and to try to bring for the table and for the disaster some solutions that we don't have in the other levels of response. So the idea is trying to help not only the European countries, but also outside the European borders, and bring more capacity and try to fix this lake between the actual capacities and the needs during the disasters.
Thank you so much, Ivo. And if you learned in our starting video, which is a video which is produced for our online training program, which we will establish by the end of this year, there was the information about 8 member and participating states of the European Civil Protection Mechanism implementing this project. But we have to mention as well that we have supporting countries, and I see Steiner here in the room. So we have the Czech Republic, we have Norway, and we have Spain in supporting this project and providing advice also to us, and this is very helpful. This means Rescue EMT is not a closed shop. It will be open also for further participations in the future, but not in the implementing phase, because it would be too complicated. I'm looking a little bit to our colleagues in the Commission. We have not to overwhelm them with additional tasks. Let's come to the question number 2. What does interoperability of rescue EMT capacity mean, and how it can be achieved? And probably I will ask Mario Di Gennaro on his opinion on this.
I can give a quite simple answer. We developed 2 couplings which fits together, and we call it interoperability. No. First, interoperability means working together, and the colleagues have already mentioned a lot of times the solidarity. And looking also to state actors, and we as Johanniter, we are an NGO, not the biggest one, but we are a big NGO in Germany, looking on the need of stuffing those kinds of capacity. For us, interoperability, beside the fact that we share the hardware, so in the sense of, and it will come later on, I guess, the question on procurement, we try to build up a harmonized hardware part of the response. And we also, and I call it software, because there is no hardware without software, which means the human resources part in those capacities are interoperable. Means a team of, let's say, French nurses can work within a Turkish capacity, vice versa. So that, in my point of view, means interoperability, and how it can be achieved is on joint procurement, as I already mentioned. The process, I might get the chance to describe that a little bit later, that staff of the partners can work in the facilities and the capacities of the other partners. And there was the modular field hospital, I call it all the time a feasibility project, which was funded by the European Commission already before Rescue, which, let's say, was the trigger that is being possible that, and I guess some of you are medical professionals in the audience, we will have 8 medical doctors working in one medical capacity under one SOPs, and that has been already achieved. So again, a tick in the box on interoperability. So working together, facilitating the collaboration between the partners, and give a good practice, and as Bastian already mentioned, maybe that can be a signal for others to join, or at least to try to do something else. That would be my answer on interoperability and how it can be achieved.
Thank you so much, Mario. And you just mentioned the European Modular Field Hospital project, which was a European project co-funded by the European Commission in the years 2017 and 2018. And the aim of this project was to try to find out how we can collaborate in Europe to build up an emergency medical team level 3. And everybody told us at the beginning, it will never work yet that you can run such kind of capacity with a mixed staff. This is totally impossible. And we came to a totally another experience based on this project. Together with the support of the Israeli Emergency Medical Team Level 3, we had a field exercise in Bucharest in 2018 and it runs perfectly. It takes only 24 hours to bring medical, logistical, and technical staff of different nations in one capacity together, and they can operate in the field as one team. And at the end of the exercise, everybody had tears in his eyes to leave now the new composed team. So the same was told to us when we tried to get the advice from the German Armed Forces Medical Service, that in NATO it will never work, that you will operate with a mixed staff of different nations on the medical capacities. So we told them this is nonsense, this will operate in the field, under field conditions extremely well. It takes a while, it takes 24 hours, but based on our experiences, it will work. Okay, coming to the next question. Why is Belgium participating in Rescue EMT, and what experiences has Belgium gained so far in developing the Rescue EMT Burn Rapid Response Team? And before I will address this question to Marcel, I will show you a short video on the Burn Rapid Response Team of Rescue out of our training program.
Welcome to the presentation of the Rescue EMT capacity, Burn Rapid Response Team, BRRT for short. The BRRT is a team of burn care specialists that is ready to respond within 6 to 12 hours of a burn incident. The BRRT assists with triage and care after initial assessment. It helps with decisions on patient distribution and referral, assists with acute burn care, cleaning, dressing changes, and supports decision-making for palliative care. The area of application of the Burn Rapid Response depends on the need. The BRRT can also deploy as a self-sustained module to carry out burn assessment and secondary triage. The degree of self-sustainability depends on the performed task. In rare cases, the BRRT can be used as a self-sustained module to deliver care for burns of minor severity. The Burn Rapid Response Team can be connected to an EMT-2, for example. It is also possible to integrate the BRRT next to a local healthcare facility with an intensive care unit to treat more complex burns. The BRRT works closely with EMT and other specialized units, such as oxygen supply, portable CT scans, rehabilitation services, intensive care, orthopedic and psychosocial treatments. The Burn Rapid Response Team, hosted by Belgium, is an indispensable part of rapid and effective burn care in the EU and worldwide. To sum it up, the Burn Rapid Response Team assists with triage and care after initial assessment, helps with decisions on patient distribution and referral, assists with acute burn care, cleaning and dressing changes. For further information, please contact info@rescue-emt.eu.
So, Marcel, now it's your part. What are your experiences based on the first steps in building up this BRRT capacity we just demonstrated here?
Well, in Belgium we're very humble and we're always very flexible, and that's our main goal in this specialized cell. We've been all over the world, Kivu, Bukavu, we've been to Armenia, the Romanian incident in the discotheque. At every major burn incident, Belgium was somewhere deployed, asked to send in expertise. So it's one of the things we can say we can deliver quality of care in this area. So we launched this burn team and this specialized cell because we think we can deliver this care, but always on a need assessment, and the needs will drive and will compose our team. We'll go for second assessment, second triage, teach the teachers, doing evaluation from Medivac to others. it's not a standalone team. Yeah, it's a standalone when we go in and teach the teachers, but whenever we need really to do specialized care, we will need intensive care beds, we will need other cells, other hospitals to be there, and we will add on. So this modularity, this specialized modularity, this flexibility is one of the things I think we're good in, and that's why we launched it. We had the expertise, we've done it several times, so let's make this now in a standard package available for the entire community.
Thank you so much, Marcel. And the question to Belgium, and I'm coming now to the question number 4. What is behind Portugal's idea for setting up a patient transfer specialized capacity in rescue EMT and how it is implemented? Ivo, this was an idea which you mentioned a couple of years ago to me, and then rescue EMT gave the chance to implement this.
Thank you, Arms. Yes, it's true. Portugal, during last deployments, even in 2019, detect one of the lake that was related with the referral capacity and the transfer capacity between EMTs and also between EMTs and the hospitals. Most of the time, the medical emergency service, and I came from a medical emergency service, are more dedicated to the pre-hospital response and not to the referral capacity or the secondary transport of patients. So, most of the times in disasters, we have these kind of problems to referral patients to other EMTs. Not a problem between referral in one EMT type 1 to an EMT type 2, but more related with who will make this transport between the type 1 and the type 2, or between a specialized care team. So, the idea for the rescue was related with this gap that we find, not only in our deployments, but also by the Commission during these complex emergencies, and we bring the transport and referral capacity classified by WHO and with modularity and flexibility. So the idea is to bring land transport and articulate also with our colleagues in the rescue that have already air medevac, for example, our colleagues from Norwegian, and to try to make bridge between all these systems, not only the transfer between EMTs and hospitals, or between EMTs and other medevac capacities to bring out for the definitive care the patients. So, in our opinion, it was a huge gap detected, and we tried to find for the rescue a capacity that could cover this area.
Thank you so much, Ivo. And Mario, you would like to add some point?
True. Thanks, Ivo. Just to share the knowledge a little bit wider, how those capacities came on the list. What is the base on the decision why we develop a referral capacity, a transport capacity, EMTs, and the other specialized care team? There was done a rating amongst the partners, and the question from our side was to Belgium, to the other partners, what was the biggest gap in your experience in the last years on health emergencies? And then the partners providing the different capacities. We've done a transparent kind of voting that you can, let's say, prioritize the needs on those capacities. And that's why we came up now with this 20/21 specialized care team and including the 3 EMT type 1s. So it's not done based on, let's say, out of the sky decision. It's based on the needs, why those capacities, and with Portugal now, the transfer specialized capacities has been set up.
Yeah, probably, Joanna, you would like to add a point, because the final decision was made by the donor, by the European Commission, which capacities can be funded under rescue EMT. Joanna, please.
Thank you. No, I just wanted to add something to what you, Mario, just said. Indeed, the countries identified or help us to identify the gaps. But what is also important, then the countries also volunteered which country would like to develop which capacity. And doing that, they chose the capacities where they have the biggest experience. Because the idea was really that it's to bring in the expertise, the lessons learned, what they know to do best to this European project. So I think that's very much the idea behind Rescue. Each of the countries comes with what they do best to create then something at the European level and something we all will learn from and will use in the future. So just to add that.
Thank you so much, Joanna. Anything to add from the panel? No, then we will come to the question number 5. How can other EMTs and the WHO EMT initiative benefit from Rescue EMT? And this is a question which is dedicated to me as a consortium coordinator. An important question. At first, we are seeing us as an important part, future part of the WHO EMT initiative. This is nothing which will be separately. We are working very closely with WHO. Thanks a lot to Jorge, who is our point of contact in the WHO EMT Secretariat. And thanks a lot to all of the mentors WHO have made available for the classification of, at the end, 18 to 19 of the capacities. Some of the capacities, this will be the very first classification, WHO classification ever. If it's coming to the 2 mobile labs, there is no classification process so far in place. The discussion about the classification process for mobile labs have just started, and the mobile labs from Germany and the mobile labs from the mobile lab from Turkey, we assume will be the first which will be classified by WHO. But also to the partners of WHO, thank you so much to make mentors available. When I see UK Med here in the room, the colleagues, you are providing some of our mentors, and this is very much appreciated to receive your advice. And this is what we would like to give as well back to the EMT community in the world. We have 2 things which probably can be interesting for you. And one thing is the training program of Rescue EMT. We have to train Europe-wide rough 3,000 people in the next 1.5 to 2 years. This means we will do this with an online training program. You saw today 2 of the videos which are out of the online training program. This platform can be on a little bit later stage also used by other EMTs because the topics are not only on Rescue EMT, the topics are more general. The other part is the patient record system, the Rescue EMT EOS, which is the name EMT operating system, which is just under development at the ECAS of the University of Leipzig. And we have shared the link for the first test version a couple of days ago with the members of the technical working group on this patient record system. And what is the idea behind this patient record system? On one side, a patient record system in Europe is a medical product according to the European medical product law. And the other thing is that this means this medical product have to be licensed. And if you change only one line in the source code, then it have to be relicensed. So it is an enormous financial effort if you have to do it for your own EMT. So it's a good thing to have something together, and especially under the view of referral patients from one capacity to a next, or from one capacity to a local hospital. I think a common patient record system can be an added value. So if you have an interest also to learn more about this, we are quite open also to implement those technical experts from your side in our technical working group for the EMT operating system. You are kindly invited to test, to comment this. This is another offer we can make. And of course, we are very much interested in your best practice, and we are more than willing to share our best practice with you. And at the end, as I mentioned before, Rescue EMT will be not a closed shop. It will be quite open for further collaborations inside of Europe and, of course, with the EMT community worldwide. Thank you so much for this. Listen to my answer to question number 5. Now we are coming to question number 6. What is Rescue EMT planning in terms of training and exercises for the capacities from 8 different nations, and how will the language barrier be overcome? I think this is an important question which is in our mind. Mario, would you have the idea to start with answering this complicated questions?
Yeah, going back to the kickoff meeting, and immediately when we started kickoff Rescue EMT, there was already in the kickoff meeting a working session on needs in training amongst the different partner. And I'm not going to say by surprise, but one need was identified with a quite high priority was language. So no, we are not going to provide language trainings inside of Rescue EMT, but due to the training on the certain level, from a leadership training up to, let's say, on the technical or operational levels of training, in our point of view, and I have to mention, Bastian, if I may, there are already established collaboration with training activities from the WHO side. I'm looking to partners which are close to our stand in the exhibition, IFRC. There are a lot of huge, let's say, training mechanism, let's call it. And we are more than happy to speak with them, not to include them, but to put training opportunities together, to give the opportunities to the health professionals in the capacities to train together, and again, training together, and to take, let's say, the fear. I'm not speaking proper English. I'm also not a native speaker in English, but I'm sitting on the stage and I'm talking, I hope at least, in a proper way, to give the every level in the capacities the confidence that they can communicate and overcome those language barriers in the sense that they are training together with the benefit of the training as such. That would be my answer to the question.
Thank you so much, Mario. Ivo, anything to add? Because Portugal will provide the training program with a train of trainers on the direct training course?
Yes, it's true. We were providing, or we will provide basic training. It is direct, disaster response core training. And the idea is to standardize this training for all the countries, provide training to trainers, and then monitoring the quality assurance of the training in countries. So with this, we can also make a bridge in these language barriers that is trying to create a pool or a roster of trainers with the same training, some initial training, and then disseminate this training into the countries. So the idea is to have a common language in this training area, but with quality assurance and supervision from one unique and specific training center. Thank you.
Thank you so much, Ivo. And we are looking very much forward, because the physical training courses will as well start in February 2025, which is not so far away. And we will start with the train of trainers courses, but of course we will provide a certain number of physical courses which are related to the European Union Civil Protection Mechanism, but which are on the other side as well related to leadership for being an expert in our common coordination team. And this is one of the aims of Rescue EMT, to build up out of a number of capacities, EMT2s and specialized care teams in EMT3, level 3, a European EMT level 3, in the case there is a requirement for such a large medical capacity. This is a part of our joint deployment strategy under Rescue EMT. So coming now to another question, and I will start with the colleagues in the Commission, and this is about the spirit in our collaboration, the spirit in the consortium. Maybe you can share your experiences, and I hope that a little bit of the spirit will also can be also changed or exchanged with you today in this lunch break session. Joanna, anything from your side?
Yes, it's actually something I wanted to talk about for a moment. And what I wanted to concentrate on is not really the outcome, the rescue EMT, but the process. Because I think it is as important as the outcome will be. So we have 8 countries, we have the Commission, we have WHO, and trying to develop something together, it means we have constantly challenges. We constantly need to negotiate. We constantly need to compromise. We need to find a common solution. And it's often challenging. It's a very challenging process, and I think we have to admit it. But we also committed to it, and we really want to develop it. And I think that's the very positive part, that everyone is trying to find a solution, that we are really trying to work on it. And I believe that in this process, we are all learning a lot. Because in the end of the day, when there is an emergency, we are there together and we need to find common solutions. And having the process of creating the EMT3, we are already getting to know each other, we are already exchanging our knowledge, and we are learning how to really work together. So for me, a big value of the whole project is really the process, is the development, is how we try to, we are going forward even though it's difficult. And at the very beginning, we were told that it's impossible to have 8 different countries speaking different languages, having different SOPs, different ideas to create one common EMT, where on top we would have almost all EU member states that could potentially work there, different doctors with different languages. And we are trying to prove that it's possible. So I think it's a difficult process, but for me, the fact that we want to do it and we are always trying to find a solution is actually the biggest thing we are gaining out of it. Besides, of course, then in the end, having the capacity.
Thank you so much, Joanna. And before I will hand over to Mario, who would like to give his opinion as the German Rescue EMT Consortium Coordinator, but as well as a consortium partner, I have to mention that it's a different relationship we have. It is not only the normal relationship you have between a donor and somebody who is implementing a project. We have a very, very close collaboration with the colleagues in the Commission, and we appreciate very much also these partly difficult discussions. And at the end, we have to follow one aim, to establish until September 2026, 21 new medical capacities in Europe. Mario, please.
Yeah, the question gives me the opportunity also to thank our consortium partners, because as you all know, the consortium coordinator, the consortium lead is one, but let's say the efforts and let's say the outcomes are from the consortium partners. So thanks to all of you who are present in the meeting, and also for those who are not present. I would not have sitting here after 5 years being with Johann Dieter if we would not have one in common in the consortium. And I would call it the passion to serve for people in need, especially when it comes to health emergencies. And what I can definitely see in the consortium, and as Bastian said, sometimes we have challenging discussions, we disagree, we agree that we disagree, but all the time since the kickoff meeting, I have to say, all the partners are outcome-oriented, and this gives us the opportunity as consortium lead to go further on and to do progress in the ambitious timeline. So collaboration, in my point of view, it's key. Sharing the same passion to develop, and also looking to the consortium partners. We have representatives from the Ministry of Health part, and we also have representatives or partners from civil protection authorities. And this is something, looking to my experience in the, I would say, last 20 years, I'm very glad that in this project, those entities are coming closer together. Because looking to the development, and we started, and you all know this, FMTs, foreign medical teams, European Medical Corps, and so on and so on. So I felt a little bit that this distance are getting closer between the civil protection response and the medical response in the project.
Thank you so much, Mario. And now I see that we have a little bit, 5 minutes left for questions from you. So in the case you will have a question, there are 2 microphones in the room. Please be so kind to address your questions to our panelists. Are there any questions from your side? I'm really surprised there are no questions. This means this lunch break session was hopefully a little bit informative for you. So at the end of our lunch break session, I would like to point out it is not our aim to develop the wheel a third, a fourth, or a fifth time. It is our aim to exchange experiences with you. It is with the whole EMT community in WHO. It is our aim to benefit from your long years experience in establishing and operating emergency medical teams. A special thanks again to the colleagues of WHO who invited us for this lunch break session today to present our European initiative. And in the case you would like to have more information on Rescue EMT, you can find us on booth number 18 here in the exhibition. We are more than happy to answer your questions also on our booth number 18. Thank you so much for joining us this afternoon, and a big thanks to all of the colleagues here who joined the panel.